Thank you, Chairman. All of you have raised a very significant issue. It's on several different fronts. Defensive medicine was raised, administrative costs. I'd be interested in finding out how much of those administrative costs are coming down from both the state and the federal government, because I know from what I'm hearing from everyone where the state and the federal government are sticking their fingers, we are driving administrative costs higher, as well as the NCQA, as was just mentioned, raising the bar every 3 years. Right now, as we go into the budget, Tabor, using even the highest cost drivers here in Pennsylvania, the Philadelphia index, we're at 0.84% increase in on Tabor, under Tabor, but you said 8% per year. What are the cost drivers that are actually making that happen? I understand there are a lot of things that are affecting the industry, but if you would highlight those.
Here can detail a little better. Most of it comes down to pharmacy costs, Representative Dush. Is that correct, Joe?
Yeah, I had some additional color, Representative Dush, and thank you for that question. I can tell you at Gateway, of every dollar that Gateway has in, we operate on 9 cents on the dollar. That's fully loaded, that's with care management, that's lights on, copier paper, salaries, benefits, and so forth. We approximately 90 cents on the dollar goes out to patient care. That leaves anywhere from a 1% to 2% margin, which should not be synonymous with profit. The Society of Actuaries in the end of 2017 put forth a very thoughtful study that highlights the components of margin, of which one is profit. So that's the first thing, just to help to understand a little bit more about how lean we run administratively. As far as our biggest cost driver, it is pharmacy. It's 40% of our medical spend. It is about 30% of our overall revenue number. We have a pipeline in the industry of biological and specialty drugs that continues to fill. The thing about these new drugs coming on the market is that they're going to be much more efficacious than their predecessor. They're going to be much more expensive, and they're going to be prescribed. And in our world, if the drug is a rebatable drug and it's approved by the FDA, we're obligated to cover it. So we're in a box. Again, we're working with the poor, the disabled, and seniors in some cases. We cannot, if you charge a copay, there are limits to what the federal government will allow you to charge. I think the upward limit on an ER copay is $6. To charge that's one thing, but if someone doesn't pay it and they still get coverage, it would cost the hospital more money to chase the thing than it would be to capture the actual copay. Cost shifting it's not possible, as what you might find a little bit more in the commercial world, where you can alter coinsurance and deductibles and out-of-pocket expenses and so forth. We pretty much have to bear the full brunt of the cost. I would say our next biggest piece is inpatient hospitals. The inpatient piece, you need to have a network in order to have a plan. Hospitals and providers need to be viable. We understand that. Again, the reimbursements that we're dealing with are pale in comparison to commercial level or Medicare. That's not a criticism, it's a fact. And so, we have provider systems that are going to put upward pressure on that because their costs are going up every year as well. Put something in perspective for you. Michael mentioned 7 or 8%, I think, of costs going up, but right now I think our trend is around 7%. The 2.1% that's been appropriated would not even cover the pharmacy portion of our trend. But Gateway's still here. Through efforts that I expressed before about what we're doing on the front end and identifying emerging risk and so forth, the 5% delta we're looking at right now as proposed with a 2.1% increase in revenue, so to speak, and 7% increase in cost to us, that's about $65 to $70 million just at Gateway that we have to find inefficiencies this year just to break even. So are the plans saving money? Yes. Is it translating into reversing the trend where the costs are going down every year? No. but we are saving enough money in order to remain viable on the reimbursement structure that we have. That has in my tenure, almost 14 years in government affairs here in Pennsylvania, it's not been commensurate with cost trend. But then again, we're working in a compelling fiscal environment. The Commonwealth can't afford that either. We have a job to do. We own that. Again, we have to have some gas in the tank in order to continue to contribute to the overall solution. Did that answer your question?
You did on the pharmacy costs and the inpatient hospitals and stuff. Defensive medicine, how big of an impact, how big of a problem is that right now?
I think that is tough to quantify for our plans. I don't have an answer for you today for that. We can certainly pull our plans to see if they can quantify it. I'm not sure I don't know. I'm not sure if the plans are keeping track of what they would view services to be defensive medicine versus appropriate services, but we will ask.
I would appreciate that because I'm hearing the same thing from nursing homes. I'm hearing the same thing from hospitals. It's becoming a greater problem here in the Commonwealth, and I would like to see us address it.
Yeah, and that has been evolving since the late 1990s because of the med-mal crisis, the med-mal situation. And I would just say that's one area where the value-based purchasing concept could be very valuable, will be very valuable, in that folks are rewarded, physicians, providers are rewarded for prescribing the most appropriate services versus others.
Yeah, we would agree. Value-based, think of it as the value-based purchasing compared to what historically has been done. There's been rewards for volume to get to the defensive medicine. Let's cover it anyway just to make sure we don't have a case on our hands, versus value where you're actually bringing the provider and the payers now together in the middle of the street rather than saying, we need more money, we don't have enough money. And it's always created this rub historically. Value-based purchasing strategies are going to bring this together, and eventually we're going to get to monetizing the outcome. So there's something to be gained by both parties involved in treating the whole person. That we would like to think that we can mitigate a great deal of the defensive medicine by doing things more on the preventive end, because we do things on the preventive end not to defend, but because we're identifying an emerging risk that we're trying to cut off at the pass, so to speak.
Right, I understand that. And if you would I'll just end with this, if you could also take a look at the quantifying some of the administrative issues, because one nursing home provider, or home health care provider I was talking with, she runs a program and they had not even completed making changes to the administrative rules that have been coming down, and there's a whole new set of rules coming yet again. When we are doing this to the industry, so much more time is taken towards pushing paperwork and adjusting policies and procedures. I realize we need to go to best management practices, but changing them on a continuous basis, I think, poses some severe strain on the system. So I would like to hear some more.
Representative, you're referring to community health choices, the rolling out of community health choices?
Not just that, but I'm seeing it throughout the entire, anything that has to do with healthcare right now, it seems everything is constantly changing, and the rule books are constantly being rewritten.
Oh, no, I definitely agree with you regarding the constant change. I thought the specific, when you were talking about a specific nursing home who, the changes, once they received information, and then you said that they implemented new changes before the deadline. Is that what you just said?
They had been going through a series of changes that the prior administrator that was there had not taken care of, and but
got it.
Even at that, the deadline had been extended, but it just seems like one after another after another.
And a lot of those changes Joe discussed that were in the mega reg that came out in 2016, and I think that may also be what they're touching on. A lot of the changes they required were just updating things, making things easier with technology and more efficient, and also Yes, that's at the federal level, that's through CMS. So the CMS administrator makes these changes, then they pass them down to us, and we have to implement them. And I know some things are still being implemented. Things that may have needed to be implemented 1/1/2017 may have gotten pushed back because we didn't have the ability to do it. And now there's going to be a new mega reg released probably later this year, so there's going to be more changes. But they're all well-intentioned, but we do just need the time to do it.
I think we have an opportunity here. I was invited down to the White House on some military veterans issues. And the administration was talking about sending people out from the department into hospitals, nursing homes, and stuff like that, looking to put a break on these regulatory changes. And they offered us the ability to send information back. So if you have that kind of information, they seemed very genuine in that they wanted to be able to put the brakes on some of this stuff and get the relief for organizations such as yours. So if you can provide something like that, I know I'd be happy to forward it back to the people that I met down there.
Okay, thank you. Representative Miller.